Hello and welcome to Slice of Piefer. I'm Dr. Piefer. I am here with the one and only Taylor Hayden. Welcome, Taylor.
Hello.
Thanks for being here.
You're welcome. Happy to be here.
How's your day going?
Great.
Fabulous.
Fabulous.
Meetings, clinic, post-call, all of the above.
Yeah. You know what? Clinic is always awesome. I like rocking and rolling through clinic, especially when I get to see people who really needed to be gotten in and seen. And it makes me feel very appreciative that they trust me to come in and see little old me about their issues. So I'm happy to help.
Little old orthopedic PA who has nearly 14 years of experience now. Yeah. She barely even said her first words.
Yeah. But it's still, I mean, it takes a lot of trust for somebody that's a new patient or even an established person to come in and trust me to take care of them. Right. Whether I had MD behind my last name or PA or anything else, that's a lot of trust you're putting in a person, and I don't take that lightly. And today was a good day. I got to help a lot of people who really needed to be seen pretty urgently. And I think about that. If I hadn't been here, they would have had to wait, and makes me happy.
Willing the good.
Willing the good. That's
so
right.
To speak. So to speak.
That's right. That's right. And it was a good mix too, like some fractures, some probable ACL tears, not so many feet, which are my not so secretly least favorite thing to see.
Feet and backs are Taylor's favorites.
They are both my least favorite. I'm happy to see them because I know that those people need to get in and get evaluated and get taken care of. But correct, it's not my favorite day when I look at the clinic schedule and just see a bunch of backs and feet.
It's back and foot day.
Yay! But I can always get them teed up and then get them where they need to go.
Correct.
Yeah.
Very nice. Yes, it was. I was on call Monday and Tuesday, so a little bit of a wild beginning of the week. Caroline is at camp, so hi, Caroline.
Does she watch?
No, maybe sometimes. Probably if her friends say something, then she would do that. I did prior to getting onto the bus, she was there with all of her friends, all 7th grade girls. There was also some 8th grade boys who were going to this camp and also a bunch of other kids. And I told Caroline and her friends that they asked for a male chaperone volunteer for the bus and for camp, and that I had volunteered for the week. She was devastated.
I bet. Yeah. Axel lost his first 2 teeth.
Nice. He
lost one and 3 days later lost the other one of his bottom teeth. He tried to set a trap for the tooth fairy.
Nice.
Like
a mouse trap or what?
So he wrote a note to the tooth fairy and had his baggie with his tooth in it. And then there was like a booklet he made. And on the last page of the booklet, it said, "I caught you." And it had like a drawn out trap, like a cage with a tooth fairy in it. Like a drawing.
But how does he...
I think he was thinking he would wake up.
Oh.
You know what I mean? Like,
yes.
Caught you. He didn't.
He did not wake up.
Yes. But it was so funny that he wrote like a book, like trying to distract the tooth fairy. And at the end, I caught you.
I think that's good. I think that's really good.
Yeah.
He's creative.
Yeah, he's pretty funny. He's quite the storyteller.
The tooth fairy is fast. And from a size standpoint, I've never seen the tooth fairy, but also relatively small.
Yeah. Well, that's what I tried to tell him. I was like, it just like everything else, you're not going to catch the tooth fairy. Like, not a thing that's going to happen.
Been trying my whole life.
Mm-hmm.
But now I gotta wait. Now I gotta wait for these old 47-year-old teeth to fall out for my next chance.
Meep merp. Don't lose your teeth.
Yep, we won't do that.
I was on an episode of Hoarders that one of the ladies couldn't find her teeth, and the therapist who's trying to help her through the hoarding and stuff, going through it, she's like, "I'm having a hard time understanding it." She goes, "I kind of lost my teeth," and they were like, "What?" She goes, "Yeah, they're somewhere over there."
Just in the piles of garbage and newspapers and whatnot.
Yeah.
I like it. Very nice. Very good. Well, what do we have for today? We have some new fun formatting that we're going to try. Taylor has been assigned this, so more things to do against your will. Before we talk about against your will, we did have some very interesting TikTok dances this week that people were popular. People were impressed to see you as the happy one and me as the one being harassed. And I was like, she harasses me all the time.
Yep. all day long.
But
Bullying.
but it's not that common that it's me is the one who's like
The downer.
right.
I know. It was nice to switch it up a little bit.
You liked being the upper.
I actually most of the time will like to be the downer. So, but it was a nice change of pace.
Nice change of pace.
Yeah.
There you go. All right. What you got? What are we talking about today?
So, we've been talking about
I'm flying in nearly totally blind. Very nearsighted or farsighted, whichever you prefer.
Near, far, wherever you are. You clapped. I thought it was going to be crickets for sure. Singing is my forte.
Agreed.
So we were talking before we got on here about, talking more specifically about some of the rules that we mentioned a lot in previous podcasts and previous talks that you've done. One that I feel like I hear you say almost every day is the need to will the good of other people. Yeah. When's the first time you can think of that you heard that phrase, or tell me the history behind why that's become a mantra of yours? You say it all the time. Right. So when do you think you started kind of coming into that or realizing that that's what you wanted to do or pursue or promote?
So willing the good is not unique to me. That certainly is not my quote. Thomas Aquinas, who is a famous doctor of the Catholic Church from back in umpteen thousand years ago.
He's a philosophizer.
He's a philosophizer. Yes. That to will the good of the other is his definition of loving someone. Mm-hmm. So it's loving as a servant. It's not loving like romantic love, but it's loving the other person. And so to will the good, it changes all of those things. It changed all of my ability to understand a lot of things, right? So how are you supposed to love your enemy, or how do you love your neighbor as yourself? Well, if you will the good of your neighbor as you would will the good of yourself, which is kind of human nature to will the good of yourself, which is interesting because that's human nature to love yourself, right? And so it's not necessarily human nature to always will the good of the other person. Mm-hmm. And so to do that, I think, was part of the dramatic message. I mean, it's a message of Christianity and multiple religions, but for me, willing the good of the other is a foundational purpose of, really, for me, everything I do. That's what I want to do, and I want to do it at work. I want to do it with my family. I want to will the good of everybody I interact with.
Well, and I would imagine it's easy to say that or think that or apply that when it's easy to will the good of somebody, right? When somebody seems like a good person or naturally talented and all these things, that's not hard to do. Can you relate that maybe to a time where maybe it wasn't? Like, can you think of a time where that was challenging for you to do? Like, specific to our occupation and our line of work. I'm sure you've got lots of personal examples, but when we're thinking about like the operating room or what we do here in medicine, can you think of anything that comes to mind?
One of the classic willing the good examples that's out there, that's not me, but it's the mom standing at the sidewalk and the kid starts to step out into the street, right? Mm-hmm. And she yells, reaches out and grabs him, pulls him back, and scares him. Not intentionally scaring him, but scares him. But you're willing the good, right? You're protecting that kid from getting hit by the oncoming car. Mm-hmm. So we oftentimes do that in different ways here in our clinic, right? We have when we do knee replacements, hip replacements, when we do surgeries, oftentimes we have really relatively difficult discussions about body mass index, about your weight, about, hey, there's a chance that if we go from a body mass index of 45 to a body mass index of 30 and you lose this weight, that your knee pain may go away even though your x-rays look like a complete garbage can, right? And I mean, we do that all the time, but you can do that in one of two ways as a surgeon. You can just push forward and replace the knee, or you can will the good of the patient even at your own cost, right? Because if I don't get to do the surgery, I don't get paid. Right. I mean, I don't make any money. But the reality is that going through a difficult surgery like that, I mean, I know people in my life who have lost 50 pounds, lost 75 pounds, lost 100 pounds, and delayed their joint replacement indefinitely, and some delayed it for 10, 15 years. Some, even though their x-rays look crazy, they didn't even have any pain. And so I think a lot of that is we see that on almost a daily basis in our clinics, in terms of helping to will the good of those folks. And then I think the challenges where we see willing the good in the operating room really is constantly trying to do the right thing, right? Always trying to do the right thing, whether that's for the patient, whether that's for the team, whether that's for the people that are around you. If your goal is always to do what's right, and doing what is right wills the good of that person, then it makes having difficult conversations easier. It makes having constructive criticism conversations. How could we have done better? How could we implement this in a better way? How could we have made sure that we had this equipment here when we needed it? What are the different things that we could do? And oftentimes I think doing that in a way where it's not a blame game necessarily, or at all, right? It's owning things together, but letting people understand that it's not personal, that it's, it's personal in the fact that I want you to do better and that I want you to be better. But people who really want to do better and be better, they appreciate having that information.
Yeah, no. And to your point, I can't tell you how many times that we've not recommended surgery for somebody or said, be happy to do your hip replacement because you have some arthritis on your x-ray, but your problem's not your hip.
Right.
Right. And we could have done the surgery. They could have had the same issues that they were having, and we could have gone, oh, well, your hip's better now, so must be your back, or must be, your inguinal hernia or whatever, and sent them on their way. And we would have been richer for it. But is that willing the good of that person sitting across from you, putting them through all that pain, recovery, rehabilitation, monetary loss, right, for having to pay for everything?
Not only having to pay for things, but to be off work and to recover and go to physical therapy, all that stuff. Yeah.
Absolutely, yeah. And so, I just had somebody I saw in the clinic very, very recently was like, I'm ready to jump on the table and have you replace my hip. It hurts so bad. But everything on their exam pointed that it wasn't.
Yeah. It's coming from
but
your
that,
back.
right, 100%. I was like, the way you just moved that hip is not your hip,
Right.
And, we came up with a plan that ultimately is what's best for that patient as a mutual decision between the patient and myself. But at the end of it, I said, look, like you just basically said you're ready for me to sign you up to have surgery. That makes me a lot more money for you to do that than for me to tell you, no, I don't think that's the right call. Let's look into this a bit more so that we go into this with all the knowledge that we can. And at the end of it, she was very grateful, but it was one of those things that, like, if we were not willing the good of that person sitting across from you, you just would have taken the money and run,
Right.
So
yeah, we're a surgery clinic. You know what I mean? Like we do surgery. Thanks for coming. It's like going to the barber shop and not getting a haircut.
Yeah. Well, it's like the example I've given before when I had that patient that was really upset. It was not when I was working for you. I was working somewhere else. And this lady is crying because that doctor just told her, I'm not your doctor, I'm your surgeon. And you don't have a surgical problem, so you've just wasted my time in this clinic. And
Ouch.
And that's not a fabrication. That's what happened. And some people see it that way.
Right.
And unfortunately, that doesn't jive with willing the good. If you care about this person who's sitting across from you, who has paid a copay, has come in and has asked you for your opinion, like that's not a waste of anybody's time.
Well, I guess as we think about that, we see some of those difficult conversations too with patients who have diabetes, patients who are smokers, patients who are suboptimal and who are putting themselves at high risk, high fall risks. And you say, well, we could replace your shoulder, but your risk for infection is higher. Your risk for having a perioperative complication is much higher. Those different things.
High risk for cardiac events if they have that from their cardiac clearance.
Correct. No question. No question about that. And I think doing the right thing, I guess we've seen it here even in the very recent past with had a patient, he came in and he had no real history of high blood pressure, no history of having an issue in the past, and said, oh, maybe my doctor was going to put me on medication, but maybe he wasn't. I can't remember. And his blood pressure was like 220 over 120 in pre-op. And the anesthesiologist was like, it'd be one thing if he had a history of high blood pressure and he hadn't taken his blood pressure medications that morning and he was hurting and he was anxious and all those different things. But it was like, he takes no medication for blood pressure. He has no history. And we're about to stress this guy even more. What are we going to do?
Right.
And so, and the interesting thing about that scenario is that you do, from the leadership standpoint, everyone turns to look to you, right? Because the anesthesiologist doesn't want to be the one who has to cancel the case, right? They don't like it. They will, but they don't like it. They like to have the surgeon. They want to have you recognize that, hey, this is not the best choice for us to move forward. And so that can sometimes be a battle in the operating room there. But the reality for me in that scenario was, for this particular guy, I said, listen, if you were my dad or my brother, I wouldn't go do a joint replacement on you and have you potentially not live to enjoy it, right? I mean, strokes are a real problem if your blood pressure is 250 over 120.
Yeah. And let's put you on some blood thinners after this surgery and just see what happens to your brain.
Right. So yeah, I mean, that was another option, another time when willing the good didn't necessarily, and you could make the argument that willed my good too, right? Because dear Lord, I would be so sad if I did surgery on a patient and they didn't make it.
Yeah.
That's not not something, but in terms of willing my immediate good, we lost a case for the day. We weren't able to take care of that patient that day. We had to go through a lot more work for myself, for the rest of the staff, everybody else, to get things where they needed to be. And we got delayed because nobody else was there ready for their surgery. So
that's just, but that's one example of many of how you have been leading in your role as a surgeon in the operating room, and you've been doing that now for 20 years. What has that taught you that you couldn't have learned or wouldn't learn by going to get, your MBA or something like that? Like, how does that apply to you?
I think, so for me, I think that high pressure and high stakes leadership really happens in that moment where you can really remove a lot of pressure by always understanding your purpose. For me, it's very easy to manage a high pressure situation when I understand that my main goal is to will the good of the person that's here, right? Whether that means we need to stop and step back and take a look and see what's going on, whether we need to reassess, whether I need to pick up the phone and call you in clinic and say, hey, Taylar, will you pull up this MRI and send me the video? I want to look at it again because what I'm seeing looks different than what I remember seeing in the clinic, and so I think those pieces, for me, that experience and being in the room where you have a team that's working towards a common goal for a person who's put so much trust in you that they are literally unconscious, right? I mean, that's a huge amount of trust for a leader, right? That's a huge amount of trust. Like, where else would I go where I would just say, hey, do whatever you want. I trust you're going to take the best care of me possible. Right. And also, by the way, I'll just be unconscious for all of it. Right. And
that's what I was going to ask is it sounds like this is something that, like, nobody outside of medicine would really understand the amount of accountability that's there.
Right.
Right. Because somebody's life is in your hands. Right.
Correct.
They're trusting. And sometimes it's elective stuff. Sure. But sometimes it's not. And so that building of that trust with the patient, but also you having trust in the team that's there.
Right.
To support you and leading them, right?
Right. And I think that's part of, when team members recognize that there's a common purpose, when they understand where you're going and what the goal is, whether you're doing a trigger finger release or a shoulder replacement or a knee replacement, then it makes it, as a leader, you can get people moving in the same direction. So it makes things more efficient. People are ready. People are thinking multiple steps ahead. People are trying to make sure that we can do as much good as we can do in the time that we have to do the good. And so if that's always your goal, then it makes life way easier. It's much more enjoyable too, because people are working hard. They're trying to do good things. And then when you can sit down honestly if everybody goes in with the same purpose, and if everyone goes in trying to will the good, then at the end, when you try to look back and say, where could we have gotten better? Nobody gets their feelings hurt, right? Because me as a surgeon, I could have gotten better. I could have done this better. I could have done this better. I always look back as a PA or a surgical assistant who's in the room, as the scrub tech, the nurse, the anesthesia team. If we all are looking to see how we can get better, then we're not only willing the good of the person we just took care of, we're willing the good of the team and the next person that we're going to take care of. And it makes those conversations easy.
Is that a part of being a surgeon that you were prepared for, like when you decided to go to medical school and stuff like that? Or is that something that you realized through the evolution of med school, internship, residency, fellowship, or once you were in practice? At what point did that become clear to you?
Well, so certainly getting into medical school, you have no clue when you're starting, when you're a college
That
student,
everyone in
right?
a room full of people who's
Right.
putting somebody to sleep and taking care of them while they're unconscious, the whole room is going to be looking to you.
Right. You have no clue. And most of the time, people go into medicine because I want to help people or
Right.
I want to fix people's bones or their hearts or
Yeah,
whatever it
I
is
think
that they
this is
want to do.
cool.
I think this is really cool. I mean, when you're 20 years old making that decision in college, to really understand and know is very, very difficult to see. I think once you get into medical school, the first couple of years are just information overload, more data and information than you've ever had in your life. And then when you get out, as you get into the clinical years of medical school and you get into residency, you get to see leaders across all types, right? You get to see really exceptional leaders who are just absolutely amazing at not only teaching but treating patients and doing things. And then you get to see folks who are not, and they exist, and they're jaded, they're upset, what for whatever reason things aren't going their way, but they're still there as part of the team. And so I think you get to see that firsthand. And as a resident, as a medical student resident, you get to make the decisions about how am I going to act in those areas. And so I think the idea that you kind of are like a born leader or something is kind of, I think being a born leader is not a real thing. There's no you learn from the people that you see, you learn from the leaders that you follow, whether that's a parent, whether that's a coach, whether that's your sibling, wherever it is, you're going to learn from those people, and then you're going to adapt the things that are going to make a difference for you and that will make a difference as a leader. And then when you can develop your strengths, identify your weaknesses, then I think you move forward in a way that is productive and wills the good of everybody.
Well, and like you were just saying, like nobody's a born leader. It's something that's learned. How then, so time's of the essence. We've got somebody coming in, they've got compartment syndrome, open fracture, whatever it is. And we don't have time to explain everything, but you now have just been thrust into that leadership position where you've got 10 to 15 random people that you're now going to be leading in that experience.
Sure.
How does that work? Like, how do you lead all those people when they all have different jobs and different areas that they're supposed to be focused on during that, while your focus is supposed to be on fixing this issue, whether it's compartment syndrome or anything else?
Right. And I think that all of it has to do with the underlying purpose. Everything foundationally comes down to what is your purpose. If you can sit down and even take a time to work through what is my purpose, what am I doing, then you can figure that out. And I think when your purpose is focused on you, when your purpose is focused on making money, when your purpose is focused on being successful or accolades or other things, all that is ambition, right? But a true purpose is something above you. It's outside of you, and it's serving someone else and serving something else. And when you have that purpose, that changes your whole outlook. Now, it will change the entire outlook for your team. Because if your team knows that, hey, I'm just doing this surgery so that I can get new rims for my car, well, then everybody's like, what are we doing this for? But if everybody knows that you're there for that reason, and not only there with gratitude, humility for the position that you're in, but you also understand what your purpose is to will the good of someone, then it makes it very easy. Whether the job is to get the patient to the operating room, to make sure the OR is clean, to make sure that we have all the right sterile equipment, to make sure we have everything we need. Each of those people is doing all those things in the background that's going to make your surgery a success, but all of it is based on the purpose, and the purpose of the leader is really the challenge, right? Because if your purpose is not, if you are a narcissistic jerk, then everything's going to take longer. Everything's going to be more challenging. People are not going to be motivated to get you where you need to be, even to some extent at the expense of the patient who's going to be on the table. And that part is where I think can be difficult. And sometimes surgeons lose sight of that. That if you don't have an underlying purpose of willing the good of someone, or if you don't have an underlying purpose that's above yourself, then the rest of the team is not going to understand what they're not going to be motivated to be there. If your purpose is centrally focused, then don't expect everybody else to do the same.
Yeah. Well, as somebody who's been part of your surgical team for a long time, I can tell you that a lot of how I respond and how I react and how I do my job as your first assistant in those cases is by watching you.
Right.
If I'm paying attention, if I'm engaged in what you're doing, what your hands are doing, and what part of the case we're in and what's coming up next, I can do my job more efficiently. If I'm noticing a lot of blood in the field, looking at the pressure, seeing if that needs to be optimized. If I'm, seeing that something's bleeding, knowing that we have enough trust that I can grab a stat, I can snap it for you and you can bovie it, or those kind of things. Like, it's just in tune knowing that. And also another part that is interesting when I think about it is you think about that person that's on the table and the team that's in the room more than any other surgeon I've ever had the privilege to work with. And one thing that really stood out to me was I remember one time we were getting ready to do a reverse on a guy, nice guy. And we were going through and you're like, no, I don't like this because he needs more external rotation because he won't be able to hold his guitar if we don't do that. And thinking about that person and willing, again, because you knew the patient well enough and had established a relationship with them to know that that was a big deal to him. Whereas I can tell you it's not something that most people do. Again, it was the willing of the good of that person. If, when I was pregnant and assisting you in the operating room, you telling them to go get me a chair because I needed to sit down because you were watching the situation and knew that I probably needed to. And that's, again, part of your team and seeing that, like, hey, we don't need this chick to pass out on the field and she's looking a little green.
I think that was my direct quote.
Yeah.
Hey, get this chick a chair.
Exactly. Yeah, I was a trooper most of the time, but I remember one time it was pretty bad, and then we ended up finding out I was running a fever afterwards. I had strep.
Sick. Pregnant, sick, miserable.
Yeah, I was like, so this ended up not being great. But yeah, I think a lot of how you lead people is in your actions. It's not the things you're saying. It's not the Thomas Aquinas quote you're giving. It's in the way that you treat not just the patient, but your colleagues that also have MD and DO after their last name, to the nurses, to the people who are coming in environmental services to clean the room. You pass that on to everybody, and I think that's the way you lead best, more than when you talk. Though sometimes when you talk, you lead me away. I just try to walk out. But.
You say it best as that's our wedding song, Chrissy and my wedding song.
Mm-hmm.
You say it best when you say nothing at all. I was like, what are you trying to tell me here? That was 21 years ago, 22 years ago now.
So if we're thinking about a high pressure situation in the operating room, again, if we're using that as kind of what we're basing this conversation around, talk to me about what it feels like in your body, like physically, when you're under a lot of pressure. If you're in a really difficult case, something that's a super high pressure system. What does that feel like? How does that manifest physically for you?
Yeah, interesting. So from a physical standpoint, I think that...
and is it something that's changed over time, right? Is it something that used to feel one way, but as now we're 20 years later, is it different?
I think early on when you don't have the, all the different arrows in your quiver to be ready to do all of the different steps, and having plan A and plan B and plan C when plan A doesn't work and then plan B is like not working either, and then you're like, well, what's next, and I think that moment is where when you start to feel a little bit helpless in the OR. It's been a long time since I've been there, but I think even as a resident, when you're like, I read everything I could read, I know what this approach looks like, I know what I'm supposed to be doing, and this does not look like what I'm doing, right? And we talk about stepping back and looking at your hands, but in that moment of just like, this doesn't look like what it's supposed to. Mm-hmm. Or I just did what I know to get this fracture where it needs to be, and it didn't work, right? And so I think those moments, they don't manifest really with like anxiety or panic or anything for me, but I can feel it. Like you can feel it when things aren't there, and I think people in the room usually know it from me because things get a lot quieter. And so I don't tend to be a person who yells or does things in the OR, but the two things that I've been told is, one, you get a lot quieter, and two, you blink slowly. I've heard that from people when I'm trying to keep myself from trying to figure out stuff. that things will move a little bit slower, which for me helps because that helps me to refocus where I need to be and what I need to do. So I think physically those things are different. But it's just really another opportunity to step back, take a breath, and try to say, okay, what's a different way that we could do this? Could I look at this from a different angle, whether you're doing a total hip or doing something else, or if you're trying to get a reduction where it needs to be.
Yeah.
And so
I would say for me, early on, I sweat a lot. Like I would get very diaphoretic in the operating room. Not where I felt like I was going to pass out or anything, but like people noticed I was sweating a lot. Like I remember the first time that I was going to stent the subclavian artery, and he told me as I was walking into the room that it was now the C1 was over.
It's now
time to do one. And I thought I was fine. I thought I was cool, calm, and collected. I thought I had real steady hands and everything. And him humbling me by telling them to cool the room because the PA was about to sweat out of her gown.
Right, your scrub hat's got sweat all over it,
Oh, yeah. And physically sometimes you can still get sweaty just because the nature of the case is wearing lead under lights, all that. That's not from nervousness or anxiety. That was because in vascular surgery and we have to wear lead, but they kept the room pretty chilly back then. And
no, that's stenting a subclavian artery as a PA student is
when I thought like I was just going to get to like close the case and watch again, right? I've been helping like guide the wire and doing that kind of stuff. I felt okay about that, but I was not thinking they were going to make me do that. And I mean, I'm glad that he had the confidence in me that he felt like I was ready. And I'm glad to say that, like, I understand the concepts behind it. I was very well researched and had knowledge. And he was, if I think about it in retrospect, he was giving me hints it was going to happen because he was asking me a bunch of questions leading up to it.
Right.
And then it happened. But like I said, sweating was a big one for me. Like I would sweat out on my cap. My shirt would just be completely saturated. I had to keep extra like clothes in my locker because I knew I was going to sweat out of them.
Got to take a shower.
Pretty much.
Yeah. But even in that moment, right? So you've got a surgeon who's walked you through what you're doing, who's examined your level of knowledge. They've focused on what you can do. They've showed you how to do it. And then the reality is that that's kind of the next step in willing your good to help you build that confidence and to recognize not only that, man, this is making me nervous, but also that you can do it. Right?
Yeah.
And so
it's a trainable skill, right?
And so
that's what I think working in the operating room uniquely teaches some people and should, is that working through that anxiety, working through the nervousness, working through even the somatic feelings that come along with that is a trainable skill.
Right.
Right. That is not something that has to dictate you or keep you from progressing or make you shy away from a pressured situation. That's something you can lean into and you can learn to work through it. Like my body's working as it's supposed to. I should be nervous because this person right here has a subclavian artery that's completely stenosed and I'm their shot of opening that back up so they have flow to their extremity.
Right.
Like, and that was, I should be nervous. My body's doing exactly what it's supposed to right now. Like it should be responding to this because this is serious.
You're sweating now.
Right. No, I'm not. But I should be able to work through that.
Right.
And that's one of the things I think that working in the operating room teaches us.
Right. Oh, I agree.
Uniquely.
I agree. I mean, it's like public speaking and like all different, like negotiations. I mean, there's all different kinds of things that you can learn, but certainly learning to manage and handle pressure.
Right. But if you're a public speaking and you get too nervous, nobody's going to die.
Correct.
You're not about to blow out somebody's artery and they're going to bleed out. And,
agreed.
And you're going to have a really ticked off vascular surgeon behind you who's going to have their work cut out for him.
Yep.
Not good. Not good.
Who put this stent in? He did.
The PA student did it. Yeah. So that's the difference though between applying those same things to other areas.
Sure.
Like, I mean, if you're in business and you're in charge of finances, you're costing people money.
Right.
We're talking about costing people their lives or their limbs.
Lives, livelihood, function, limbs, all of that tends to be on the line with the things that we do. Yeah. No question.
Can you think of an experience or a time where you were in the room, whether it's OR, ER, something like that, where you were the only person who knew what the next right thing to do was? Like where everyone was looking at you for that decision? and that guidance and that leadership.
So, the classic one that I talk about a lot is the compartment syndrome one. And I don't know that in those moments that I'm the only person who knew that, hey, this is compartment syndrome, but I was the only person who had the authority to make the decision, right? Who had to say, hey, we've got to go now. I think that we see that in multiple different areas. Now, when we see some of those complex shoulders, when we're in scoping complex shoulders with big tears and major issues, there's definitely times when you say when I know that nobody in the room knows what we're doing next, right? Whether we're going to put in one anchor or whether we're going to put in 6 anchors or whether we're going to grab this and side to side repair and then do these different things. And so I think there are those moments certainly in the operating room where the expertise and training are there and the rest of the room is waiting, right? And having people waiting for you is a privilege, but it can be a little lonely, right? I mean, because there's nobody else, right? If I make this choice and it doesn't work, there's nobody else to look to besides myself for why it didn't work. And I think you find a little bit of defense mechanism sometimes from surgeons to blame somebody else, like, oh, well, whatever, the implant didn't work or we didn't put this in the right spot. But ultimately, as a surgeon, you know the anatomy, you know the pathology, right, the problem, and you know the opportunities that you can, or the ways that you can fix it. And now you have to execute.
And check.
And make sure that it worked.
Right.
And so I think when you have all of that and you're the only person who's ultimately the ultimate decision maker, that can be pressure and that can be a challenge. But when you have the rest of your team there to help you, and I think that that's the other piece when you're sitting in that room and you say the team knows that they're part of the team, right? They know that they have a say. And if they see something that they can ask a question or they could make a suggestion, I think that is a sign, in my opinion, of a very mature leader. If you're willing to let somebody, I mean, the worst case scenario is they say, hey, I think we should do this. And you as a leader say, thank you, we're not doing that. Right? But nobody's feelings are hurt. It's not been any waste of my life or effort. And you've given that person an opportunity to participate. And the fact that they're willing to participate and they have the resolve and the courage to say, hey, what if we tried this, right? And you have so many people in so many places when it's in the operating room, whether it's in business, who are yes men and yes women and, who wouldn't stand up and say, hey, what about this part, right? What about the angulation that you're leaving on that fracture? What about, the gaping hole in the rotator cuff? What about that, right? And it may be that you're leaving it alone. It may be that they're holding you accountable. It may be that you didn't see it at all. But if you're not practicing, if you're not working in an environment where everybody understands that the purpose is not for the surgeon to get home and the purpose is not for all of us to go have margaritas afterwards, the purpose is that we're going to will the good of this person, then everybody in the room can ask questions and can give comments and can make suggestions without feeling like I'm going to get judged. And everybody will be better in the end. So for me, that's why, especially for our equipment reps who are in the room, I try to encourage them to say, hey, guys and gals, listen, I get it that you get phone calls, but the more people that I have looking at this so that we can make the right decision, the better. And so if you see something that you think would work, then speak up and we can go from there. And so I think that part is a different, it's a leadership style that's not easy. It takes a little bit more time because you are listening to your team. But ultimately, I think it retains team members. It makes people feel, it doesn't just make them feel good. They know that they're valued. That they're valued, right? And that part I think is important. I think is very important.
Yeah, and it creates better outcomes.
Right.
Right? I mean, and at the end of the day, again, we're willing the good of everybody in that room, including and maybe most importantly the patient, right?
Right.
Like we want them to have a successful outcome. And so if you don't speak up because of whatever it is, fear, not being engaged, like in what's going on, not feeling motivated, whatever it is, like that case suffers as a result of it.
Right.
Because there's something unique that every person brings to that team.
Correct.
Right? If the environmental services person is not feeling it that day and doesn't do a great job of cleaning, and we go touch a light handle that's got blood on it still from the previous case.
Right.
Right? You know, that's a big deal. Like, that's that. Or if sterile processing, there's a hole in the, gosh forbid that there's a hole in the cover on those sterile implants, right?
Yeah.
That means those implants, which may be, or that tray, which may be the only one, we have to do it. And so that person that surgery goes back another 2 hours or hour to be reprocessed. It's everything.
And I think that part is, I mean, in empowering your team to be able to feel that they can, as a strong leader, if you can empower your team to feel like I can do anything that I can as long as I'm willing the good of this patient, then when somebody comes to you and says, oh, hey, this instrument is not sterile, or hey, we just got a bunch of labs back and this person is not in a good spot for this surgery today, right? Instead of them getting verbally dressed down by the surgeon for not getting the labs there in the right time, we can deal with the timing and whatnot at a different time. But the time that they don't come forward because they live in a state of fear, they live in a state of concern, they are struggling with making those decisions, and you as a leader haven't established an environment where people feel comfortable talking to you, at least feel comfortable bringing things to you that are, purpose driven. And then if that environment and that responsibility is the leader's responsibility, 100%, right? Because if someone's too afraid to tell you something that it's going to ultimately affect the outcome of the case, or your problem, whatever it is, whether it's surgery, business, whatever, if someone's too afraid to come talk to you because of your responses and your reaction as a leader, then ultimately you can't be surprised as a leader when things don't go the way they're supposed to.
Yeah. It's not an effective leader.
Correct.
It's an effective scarer.
You're very good at scaring people.
Work for Monsters, Inc.
Well, and I think that the hard part about that is that in the very, very short run, people will work hard to avoid pain, right? And so you can get lulled as a leader into a habit of making people's lives miserable in order to get things done quickly.
Get the outcome you want, which is that I get.
Right. And that is a very immediate, short-term, goal-oriented focus that ultimately will not bear fruit in the future, because you will lose team members, you will lose, you'll have bad outcomes, you'll have patients who don't get the optimal treatment because people are afraid to come forward and tell you what they need to tell you, and they're afraid to contribute as part of the team. And ultimately, the best of the best team members just won't tolerate it, and they'll go someplace else. So, man.
Yes.
Man, that was super serious.
It was a lot of serious. What should we talk about now?
We did dance around in the hallway. I had multiple people ask if we were building a new building. I was like, that's the same building.
I was just happy you couldn't see the walls very well in the background of that video.
And the drawings on the walls.
Correct.
Yeah, that's true. Now people are going to go zoom in.
You know where that song's from, right? Like what famous movie?
Well, somebody commented about it in something about
My Best Friend's Wedding.
My Best Friend's Wedding.
Yes,
Nice.
it's so good. That's what I think of every time I hear that song.
I saw that you responded back.
Yeah, samesies. Yeah. No, it's such a good movie. And so when I was, they were like, we could do this. I was like, I will do that one. That movie makes me think of my childhood friends who I watched it with.
Yes.
We went and saw it in theaters. It was a whole thing. I loved Julia Roberts. Like any movie she was in, I was going to go see it.
Well, I got hit up for a couple of people to come in, hopefully soon for the podcast.
What?
So I know, isn't that great?
Yeah.
So hopefully in these weeks ahead, we'll have you on this side again. We'll see.
Or not at all. Could just be you with your guests.
Taylor's like, I just want to go work out.
No, I worked out at 5 a.m. Thank you very much.
Well played.
Kids are off for school for the summer,
I was
so it's
answering
easier.
ER calls at 5 a.m.
Yuck.
Yeah, that was good. We had real patients with real problems. And so it was like the real world on MTV.
This is the real world.
Yeah. And I mean, that was really good. Satisfying for me for just to get to help people get better. Because I know for sure the infection that we saw, the other stuff we saw is going to those folks are going to get better because we were able to take care of them. So the
Awesome.
sacral insufficiency fractures, hard to say.
Time will tell.
Time will tell.
Get it? Tail.
Telltale, like a telltale sign, like a telltale bone.
Exactly. Close to it.
Yes. All good. Well, Taylar, thanks for being here. Thanks for going through the Q&A excitement.
Happy to help.
And we'll see how that does. I think it's going to do fabulous.
Fabulous.
All right. We're playing you off.
Okay, out.
Taylar's